Hello everyone, this one is the last day of the international webinar series, Facet of Pharmacy. Hope so you have enjoyed last 3 sessions of this international webinar series, which is delivered by the eminent speakers having a more than 25-year experience. Once again, here we are back with the new topic or gene therapy in diabetes mellitus. So here I welcome you all. I am Assistant Professor SAGAR ANDE from Dr. Rajendra GODE Institute of Pharmacy. I heartily warm welcome you to all the participants to this international webinar series organized by joint venture of Dr. Rajendra GODE Institute of Pharmacy and Dr. Rajendra GODE College of Pharmacy, co-sponsored by Unique Pharmaceutical Laboratories Daman, Zim Laboratories Nagpur, and Sun Enterprises Rwanda. So here I welcome to all the eminent speakers, our mentors, our organizing team, and most importantly, the participant without whom this is going to be a success story for this international webinar series. I here welcome you to all. Now I would like to request Professor Chaitanya GULHANE sir for give the short introduction of today's topic. I am going to unmute your mic, sir, so you can proceed with.
Thank you, sir.
Yeah.
Good morning to everyone. I am Professor Chaitanya GULHANE, Assistant Professor, Dr. Rajendra GODE Institute of Pharmacy. Welcome today's honorable guest speaker, Dr. Ravikiran Panakanti sir, and all the participants in this last session of this webinar series. This webinar will focus on the emerging techniques in the gene therapy for diabetes mellitus, especially on the challenges and success of human islet transplantation as a cure of type 1 diabetes mellitus. Hope so, this webinar will ignite and encourage the minds of the young scholars in our country to focus and work in this particular research area. Thank you, sir.
Okay, thank you, sir. Now it's the time for the inaugural of today's session. So I would like to hand over the session to Professor HARIGOPAL SAWARKAR, sir, Principal, Dr. Rajendra GODE College of Pharmacy. Over to you, sir.
Thank you, Sagar, sir. Thank you. Hello, everyone, and welcome to today's session. This is the 4th day of this international webinar series. Myself, Professor H.S. Sawarkar, Principal, Dr. Rajendra GODE College of Pharmacy, AMRAVATI, on the behalf of my management and whole staff of our both institute welcomes you once again. I would like to introduce the today's eminent speaker, Dr. Ravikiran Panakanti, who is with us from Roosevelt University College of Pharmacy, US. For today's webinar, welcome, sir, once again. Today, he will enlighten us on the topic gene therapy useful in diabetes mellitus. Once again, I would like to thank our co-sponsors like Unique Laboratories Limited, Daman, Zim Laboratories Limited, Nagpur, Sun Enterprises Limited, Rwanda. And lastly, I request to all participants to make these sessions much more interactive and to upgrade their knowledge. Once again, I thanks and over to Professor Sagar, sir.
Thank you, sir, for this introductory part and
thank you
in this session. Now I'd like to request Professor Suraj Yadav, sir, to introduce to the today's our eminent speaker for this session. Over to Yadav, sir.
Thank you, sir. I'm audible?
Yeah, you are audible.
Good morning to everyone and good evening to our today's eminent speaker. Myself, Suraj Yadav, Assistant Professor, Dr. Rajendra GODE College of Pharmacy. I feel elated to introduce such an eminent speaker to everyone, Dr. Ravikiran Panakanti sir. Sir completed his Ph.D. in pharmaceutics in UTHSC, Memphis, USA, and B Pharmacy from Jawaharlal Nehru Technological University, Hyderabad, India. He currently working as an associate professor of pharmaceutics at Roosevelt University College of Pharmacy, USA. Dr. Panakanti's research is focused on developing novel gene delivery systems that are safe and effective. He was worked primarily on improving the treatment of diabetes mellitus and liver fibrosis. Dr. Panakanti developed adenoviral vector encoding vascular endothelial growth factor, hepatocyte growth factor, and interleukin 1 receptor antagonist genes, which can help in revascularization of isolates and protect the isolates from human medicated destruction. He also worked on ischemia perfusion injury to liver. His lab is currently working on novel treatment strategies, including proliferation of beta cells for treating diabetes and screening novel compounds. Dr. Panakanti has published many peer-reviewed publications and scientific presentations. He also serves as an editor and reviewer for several peer-reviewed journals. This is the brief introduction of today's speaker from my side, and I'm sure that you will enjoy today's session. Thank you so much. Now over to you, Professor ANDE sir.
Thank you, Yadav sir, for giving this short introduction about our today's eminent speaker, Dr. Ravikiran Panakanti sir. So without wasting more time, we are now going to learn and enlighten this session with upgraded knowledge, which will be delivered by our eminent speaker, Ravikiran sir. Over to you, sir. Now the session is your.
Yeah. First of all, thank you very much for your kind introduction and also inviting me to share some of the research work that I've done in the area of diabetes mellitus. So let me share the screen so that you can see the presentation.
Yes.
So once again, good morning, everyone. So my topic today is, as it has been mentioned, is gene therapy for diabetes mellitus. And my focus specifically is on trying to develop some or trying to deliver certain therapeutic growth factor genes or proteins that can be beneficial in maybe possibly finding a cure for diabetes. So again, just a brief introduction. As we all know, regarding diabetes, the major concern is that the islets or the insulin producing cells or beta cells, they generally they basically stop secreting insulin, especially in case of type 1 diabetes. And also in the case of type 2 diabetes, it can be either there is diminished secretion of insulin. So the amount of insulin that has been secreted is not sufficient to maintain the normal glucose insulin homeostasis, which is very important for proper functioning of the body. So again, in this illustration, you can see a normal cell, there is production of insulin from beta cells, but in a non-functional islet cell, the insulin secretion is not present, or the insulin producing cells, especially in a type 1 diabetes patient, is destroyed. So, sorry, I think I skipped. So we all know, I mean, there are two different types of diabetes, type 1 and type 2. So type 1 diabetes, again, is generally known as either juvenile onset diabetes mellitus or insulin dependent diabetes mellitus. As the name implies, again, in type 1, there is no insulin production. if you look at the etiology or how diabetes is type 1, especially we generally say that type 1 diabetes mellitus is more prevalent in young people or in adolescents. So we really do not know what are the major causes for a person becoming type 1 diabetic. But there are studies which say that it can be either environmental factors, genetic factors that basically result in an autoimmune reaction where our body's own immune system is going to kill the insulin producing beta cells. And one of the major drawbacks with treatment or trying to develop a therapy for diabetes is that we are born with a specific set of beta cells or islet cells. So once you see that once those islet cells are destroyed, there is no way we can get them back. They cannot be regenerated. So that is why till now there is no cure for diabetes. We try to manage type 1 diabetes or in certain cases of type 2 diabetes by giving daily doses of insulin. Type 2 diabetes can also be treated by other oral diabetic medications. But if you see with age or with how the person is getting the therapy for type 2 diabetes, over a certain amount of time, type 2 diabetes will progress into type 1 diabetes, where a person has to take daily insulin injection. So, so what are some of the ways by which we can possibly have a cure for diabetes? So there has been a lot of research that was done in trying to see if you can maybe transplant the whole pancreas, but it has been so like any transplantation process, you generally use immunosuppressant drugs. So thereby there are side effects. And when you look at pancreas, anatomy of pancreas, it's a very delicate organ. So it is very difficult to basically isolate the pancreas. So in 2001, scientists in University of Alberta, Canada, they basically came up with this human islet transplantation process. So in this particular process, you basically isolate the islet cells from a cadaveric donor. So you basically take out the pancreas and then isolate the islet cells from the pancreas. And then you do the transplantation of only the islet cells. So pancreas is not needed. And the way you do the islet transplantation is once you isolate the islets are collected and they are basically transfused into the hepatic portal vein of the liver. So, and it's a simple process. You don't need to do any surgery. You use ultrasound to basically point out the hepatic portal vein. So you basically make a small incision in the abdomen, isolate the hepatic portal vein. Nowadays, you can even do it by using ultrasound. So you can isolate the hepatic portal vein and inject the islets into there. So the advantage being the islets basically reach the blood circulation. They are in the liver where liver is a chief metabolic organ. So when there is, and the major goal for us is to make sure that there is a balance between or homeostasis between insulin and glucose. So if the islet cells are already in the blood circulation, so whenever there is a signal that there is an increase in glucose, the islets will secrete insulin, thereby glucose will be metabolized or the levels of the glucose will be brought down. So it's a simple process. And for even islet transplantation, we will look at some of the challenges associated with transplantation of islets. So basically, there are three major reasons. So I mentioned to you that this particular protocol was developed in 2001, but we may not have heard about it, heard about human islet transplantation a lot. So like any organ transplantation, one of the major drawbacks with any transplantation procedure is there is immediate graft rejection. The same thing applies to islet cells too. In simpler terms, you can say that the islet cells that are transplanted, they are basically killed by, or they're basically killed by apoptosis. So if you look at some of the reasons why apoptosis can develop, it can be because of the cytokines or the immune reaction that can be developed from the islet cells that are transplanted itself, or we are basically summarized three different reasons which are detrimental for the transplantation or for the success of the transplantation of the human islets. So the first one basically is loss of viability during isolation and in vitro culture. So it basically, so this one again is a problem that has been rectified now. So as I mentioned to you, pancreas is a very delicate tissue. So when you try to isolate it, there is sometimes during that isolation process, there is loss of viability of islet. The islet cells get damaged. So, and also we use an enzyme collagenase that is basically used to digest the tissue and isolate the islet cells. So there were problems with using a proper purified grade of collagenase, which has now been rectified. So nowadays we even have a Ricardo method of isolating the islet cells, which can basically has greatly enhanced the yield of islet cells that are required for human islet transplantation. The second reason, which is important, is if you look at the anatomy or the anatomy of islet cells that are present in the human body, they have very deep or very intricate vasculature, there are plenty of blood vessels surrounding the islet cells, which is very important because these blood vessels supply the nutrients and oxygen to the islet cells. So when we basically isolate the islet cells from the pancreas, the blood vessel, the vasculature is broken down. So the islets will not receive any oxygen or nutrients, because of which, again, that is another reason why the islet cells can basically die immediately, or there can be graft rejection immediately after transplantation. The third reason, again, which I have briefly mentioned to you, is there can be both inflammation and immune-mediated cell death. So basically, there are cytokines that are released either from the host tissue or from the islet cells that are transplanted itself, and that can basically kill the islet cells that are transplanted. So in the top figure, again, I mentioned human beings, we generally transplant the islet cells into the hepatic portal vein. But in case of animal studies, when we're trying to develop a therapy and see whether that particular therapy is beneficial, we generally use NOD skid, non-obese diabetic severe combined immunodeficient mice. And we transplant the islet cells in the kidney capsule of the mice. Okay, so the reason we do that is the kidney capsule is basically the least immune privileged zone in animals, in the mice. So it means that there is very less immune activity. So when we're trying to look at whether the therapy that we are using, whether it's functional, then we basically do the transplantation in the immune capsule, in the kidney capsule. So thereby it can be functional. But these are, again, two major reasons that can basically result in immediate graft rejection or death of the islet cells after transplantation. Is my audio clear? Are you able to hear?
Your audio is clear, sir. No problem.
Okay. So by looking at the reasons, we basically figured out that these two are the major reasons that basically result in the failure of these human islet transplantation or islet transplantation process. So, so here we came up with the approach of gene therapy. So which again basically uses, in our case, we are trying to express genes, in this case, therapeutic genes, that can be used to correct certain problems that we see, certain physiological problems that we see in a particular disease state. In this particular case, we wanted to basically express or deliver two genes. One is vascular endothelial growth factor, and the other one is interleukin-1 receptor antagonist. So the uses or the therapeutic uses of these two genes are, as the name implies, the vascular endothelial growth factor. So endothelial means blood cells or cells which will basically help in the buildup of blood vessels. So this particular growth factor plays a key role in revascularization. So our goal was to make sure we can revascularize the islet, so we can basically help enhance the revascularization of blood vessels around the islet cells immediately after transplantation. So thereby we can overcome the problem of hypoxia, lack of oxygen, lack of supply of oxygen to the islet cells. And then the second hormone, second protein or gene we wanted to express was interleukin-1 receptor antagonist, which is again used to protect the islet cells from apoptotic mediated cell death. So that was our hypothesis. So the next step is when we want to express genes, there are two methods that you can use. You can either use a viral vector or you can use a non-viral vector. So when you say a viral vector, there are different types of viruses that can be used for delivery of these genes. You have adenoviral vectors, you have adeno-associated viral vectors, you have retroviral vectors, you have lentiviral vectors, you have herpes simplex virus vectors. When you look at non-viral vectors, you have plasmid-based vectors. The major difference between plasmid and viral and non-viral vectors is the expression of the protein is very high when you use a viral vector compared to that of a non-viral vector such as a plasmid vector. And when you look at islet cells, so when you're trying to express a gene using a viral vector, you have to, in case of viral vectors, you have to transduce the viral vector into the cell you want to express the gene. So in our case, we want to express those two proteins, those two genes in islet cells. So when you look at the islet cells, these are non-dividing cells. So you have to choose a vector that can basically transduce a non-dividing cell. So adenoviral vectors are basically viral vectors which can transduce these non-dividing cells or islet cells. Another advantage of using an adenoviral vector is, so these adenoviruses are commonly seen in cold. You know, like we are seeing the problem of coronavirus. Adenovirus is also a type of virus which basically affects human beings and results in respiratory problems, usually common cold. So in simpler words, we basically have the receptor that is present that is basically needed for the adenoviral vector, which is Coxsackie adenoviral receptor. So one advantage, we can basically use adenoviral vector so that it can transduce the islet cells, which are non-dividing cells. Then one of the drawbacks of using a viral vector is, again, there can be immune-mediated reactions. So we basically used an adenoviral vector it's basically replication deficient. In other words, this adenoviral vector does not integrate into the host genome. It's not going to replicate. It's replication deficient. It cannot replicate, and it will immediately start expressing those genes within 14 hours after 7 to 14 hours after transduction. And it can also, it also shows transient expression. In other words, the expression of these two genes when you use adenoviral vector will be only for 10 to 14 days. That is the phase where you generally see immediate graft rejection. So when you use these adenoviral vectors for this particular, for the expression is only for 14 days, then it means that is sufficient enough for us to make sure that the survival of the islet cells can be enhanced. So we basically, and the other thing we did was we basically developed an adenoviral vector which was bicystonic. So bicystonic means, cystone is another term for gene. So bicystonic means you are expressing two genes in one vector. So we basically took adenovirus plasmids and we initially inserted the genes IL1RA and VEGF into two plasmids, plasmid P3.1 and P1.2. And then we basically took out the major expression sequences of this particular, of both these two plasmid vectors, and then we inserted it into the AdenoQuick 13.1 cosmid. So the use of, we basically need this particular cosmid, AdenoQuick 13.1 vector, because this particular cosmid has all the expression cassettes required for expression development of this adenovirus that can express two genes simultaneously. So these, once we inserted these two genes into the AdenoQuick 13.1 cosmid, then these were transfected into AD293 cells. And then once you do that, these viruses will replicate, and then you will basically collect the supernatant, or you basically use a adenovirus titer kit that can help us in determining the concentration and purity of our viral vectors. So this is basically the construction phase. So we basically made an adenoviral vector that was bicystonic. In other words, it can express two genes simultaneously at one time. So the advantage being, instead of using two different adenoviral vectors, you are using only one vector. So the backbone of the virus load, or the virus load, is basically we are trying to decrease the virus load so that that can even further minimize if there is any immune reaction from these from the use of these viral vectors. Once these vectors were, once we constructed the vector, the second thing was to make sure we did some tests to ascertain that there was these vectors were indeed expressing those two genes. So we wanted to see whether, so we basically did some studies, and we want in vitro studies, and we wanted to make sure that there was both, or we basically saw that there was both time and dose dependent increase in expression of those genes. So in this particular scene, you can see, so this is basically the expression. So when we try to use the viral vectors, we generally determine the concentration using the term called MOI, or multiplicity of infection. So in this particular graph, you can see N basically means we are trying to compare. So N is basically a control. So N is basically control cells which are not transduced by any adenoviral vector. Then we also try to compare the expression of these proteins from adenoviral vector to that of a plasmid vector. So before construction of these adenoviral vector, we also made a plasmid bicystonic plasmid vector. So you can see basically there was the expression of the genes, both IL-1RA and VEGF, was much higher in cells that were in islet cells that were transduced with adenoviral vectors compared to that with a plasmid vector, and also compared to that with a control, compared to that with the cells where there was no, which cannot be basically transduced with the viral vectors or plasmid vectors. And the concentration terms that you see are basically 100, 500, 1,000. That basically means the multiplicity of infection, or in other words, when you use a multiplicity of infection of 500 or 1,000, it means that 1,000 viral particles are going to infect one cell. So that basically determines the concentration of the viral cell. So this is basically a theoretical marker. So we assume that when you use a concentration or multiplicity of infection of around 1,000, it means that 1,000 viral particles, which is basically the viral particles that express both genes VEGF and IL-1RA, they are going to infect or transduce at least one cell. So this was protein expression. So we could see that there was a very time and dose dependent increase. So we did basically at two different times, one is day 1 and day 3. We collected the supernatant. Both these proteins are secretory proteins, so we could basically easily measure the concentration of these proteins in the supernatant, cell supernatant. So we collected at two different time points, and we could see there was an increase in concentration of both the genes with the increase in time. So once we did the protein expression, so we also wanted to make sure, because there can be sometimes endogenous expression of these genes, VEGF and IL-1RA, from the cells itself. So we wanted to also make sure that there was protein expression at the mRNA level. We can see that the gene expression is indeed coming from the viral particles. So we did the same thing. So we collected basically the cells. We isolated the DNA, converted, did a reverse transcription, and did real-time polymerase chain reaction. So that basically would tell us that there was at least 100-fold increase in expression of those two genes. As there was an increase in concentration, there was an increase in gene expression for both the genes. So that basically proved that indeed the adenoviral vector was expressing those two genes that we have inserted. So the next thing, we also wanted to make sure that so this particular PCR analysis basically tells us that sometimes when you do experiments, you see that there is indeed, we are seeing an expression, mRNA levels or the gene expression of the genes that we're looking for is high when we do the real-time PCR analysis. But we have found out that sometimes even blank adenoviral vectors, they can also produce, we could also see false positive results. So in this particular experiment, we wanted to make sure that the expression of the genes that we are seeing, they are indeed coming from the viral vector. So we basically also added another control, which is an adenoviral vector, which didn't have any genes inserted into it. So when we did the real-time PCR, we could see that the expression of the protein, I'm just showing it this for vascular endothelial growth factor, the expression of vascular endothelial growth factor was much higher when you compare that to the control, so non-transduced cells, and also to the cells that were transduced by the blank vector. So this kind of confirms that, yeah, indeed, the vector that we have constructed is now expressing both the genes, which is critical. So the same thing we have seen with interleukin-1 receptor antagonists. We could see that there was pretty high expression of interleukin-1 interleukin-1 receptor antagonist when we transfuse the islet cells with the adenoviral vector that express both the genes. So the next thing we wanted to see was, and again, all the experiments, all the results that I have shown you, they are all in vitro studies. So we are basically, but these studies were done on human islet cells. So we basically get human islet cells from a research facility and we work on them. So the next thing we wanted to do also, once we confirm that indeed we have made the construct, we have those two genes that are expressed. So we wanted to make sure that whether the vector is going to, how is it going to affect the release of insulin from these islet cells. So we did a glucose stimulation index. In other words, we basically transfuse the cells. So N is basically the control cells, which are untransfused islet cells. And then we basically use two different concentrations of adenoviral vector. So MOI of 1000 and 2000. So there are two things we wanted to see. We wanted to make sure that there was no detrimental effects by using this adenoviral vector. So the adenoviral vector itself would not cause any damage to the islet cells. And then we also wanted to see whether these islet cells would not affect the insulin release efficiency of these islet cells. So after we transfuse these islet cells with the adenoviral vector, we basically subjected this particular islet cells to two different concentrations of insulin. One was two different concentrations of glucose. So we basically added 2.5 millimolar concentration of glucose to the cell culture media, and then we incubated the islet cells for 1 hour. And after 1 hour, we collected supernatant and measured the insulin amount. And then after that, we basically added cell culture media that basically contained 22.5 millimolar concentration of glucose. So we are basically subjecting the cells to low concentration of glucose and subjecting the cells to high concentration of glucose. And then we measured the insulin levels and compared the ratio. So basically, you can see usually for glucose stimulation index, any value above 1 is better. So it means that the islet cells are functioning well. So we could see that there was not much difference between the islet cells that were not transfused with the viral vector and the islet cells that were transfused with MOI of 1000. But we could see that there was a glucose stimulation index was less for islet cells that were transfused with adenoviral vector at a higher concentration of 2000. So there are two things that we achieved with this particular experiment. We found out that at a concentration of 1000 MOI, the islet cells tolerated them better. So we basically we used this particular concentration for our further experiment. So the next step was again, once we did all the in vitro work, we wanted to see how these. So for our islet transplantation process, again with gene therapy, we use a method called, the process that we use is known as ex vivo transfection. So in other words, we basically take the islet cells and then we transfuse the islet cells with adenoviral vector, and then we wash off the cells so that we are not going to inject any adenoviral vector that is present in the cell culture supernatant. So we are only going to transplant the islet cells that are being transfused by the viral vector. So that's basically known as ex vivo transplantation. So the next thing, so we wanted to test it in vivo in non-skid mice, how this vector is going to basically, whether it's going to decrease the blood glucose levels in diabetic mice. So we basically induce diabetes in the mice by using streptozotocin, which is again a very well established protocol. So once in these streptozotocin-induced mice, you can see at the initial part of the study, the blood glucose levels were pretty high, around 500 or 400. Between so anything above 250 or 300 is generally considered as diabetic. And then we had mice which have very high blood glucose levels. So at this particular time point, we basically had 3 different groups. So we transplanted basically the mice. So we did the transplantation in the kidney capsules of mice. So the one group was islets that have been transduced with the viral vector VEGF-IL1RA. The second group was mice in which were transplanted with the islet cells that have been transduced with the adenoviral vector, blank vector. Blank C is basically a blank gene. It does not have any therapeutic function, so it's a blank vector. And then we compared these two basically groups with mice that have not been mice that have been transplanted with only islet cells which are not treated. So we could basically see that the mice which have been transplanted with the islets that have been transfused with the adenoviral vectors, there was a significant decrease in blood glucose levels. And we did this study for around 1 month, 30 days. So at the end time point, again, I'm not showing this data here, but I'll show in the other slides. So after 30 days, after around 30 days, we basically did a process called nephrectomy, where in the mice, we basically removed the kidneys into which we transplanted those islet cells. And then we could see once we removed the kidneys, there was immediately the blood glucose levels increased to a very high level, to a diabetic level. So that basically showed us that indeed these, the adenoviral vector transduced islet cells were expressing those 2 genes, and those genes were helping in enhancing the survival and functionality of the islet. We also tried to, at the end of our experiment, we also we collected the blood serum levels, and we tried to measure both the C-peptide levels and insulin levels. And in this case, since we have done the experiment in the mice, but we are using islet cells, so we will be basically producing human insulin. So we did the study for both human insulin and C-peptide, and we could see that there was an increased level of human insulin in adenovirus HVG-IL1RA transduced islets compared to that with either blank or non-treated islets. And the same thing we could see for C-peptide for adenoviral VEGF-IL1RA transduced islets. So basically, this indeed tells us that if this particular the method of gene therapy where we use a viral vector to deliver therapeutic genes can enhance islet transplant outcomes. So after this, then we had some challenges with the use of VEGF. As I mentioned to you, vascular endothelial growth factor, the major use is again revascularization. So we then we just figured out that we applied for some grants, and we did get a grant, but there was one comment we always used to get, because vascular endothelial growth factor, even though it's beneficial in our transplantation scenario, because islet cells need revascularization, but when you look at the study, they say that VEGF is very important. It's basically, it can enhance the condition of cancer, because cancer cells need a lot of blood supply. So if you look at cancer cells, one of the markers is VEGF, because VEGF is overexpressed, because these cancer cells will need a lot of blood supply and they will grow. So we then tried to change our therapeutic gene from VEGF to hepatocyte growth factor. And one of the reasons that we did it, because if you look at the functionality of hepatocyte growth factor, again, one of the main, it's also a growth factor that is known for revascularization. Apart from revascularization, we figured out that hepatocyte growth factor, it promotes beta cell proliferation and also function survival. In other words, it basically helps in protecting it has 2 uses. One is it will promote revascularization. Second, it can also protect the islet cells from apoptosis mediated cell death. And the third one, the major one that I have not mentioned, is it can also help in improving or can enhance this beta cell proliferation. So apart from if you remember the slide that I mentioned to you, some of the major reasons for lack of success of islet transplantation, So one of the other drawbacks of islet transplantation is that we do not have enough supply of islet cells. So when you look at the human islet transplantation process, we need at least islets. We need the isolated islets from at least 3 cadaveric donors. That is sufficient for one diabetic patient to become insulin independent or basically show some better effects, better effects in decreasing glucose levels, decrease in episodes of hypoglycemia and others, and better overall or decrease in development of other diabetic complications. So for that to happen, you need a larger number of islet cells. So nowadays, the other side of the therapy is to see, are there any ways that we can use to enhance this beta cell proliferation? So looking at these all features of hepatocyte growth factor, we basically developed another adenoviral vector where we just replaced the gene VGF with HGF. And similarly, we did the same studies. We did the in vitro studies where we could see there was both time and dose dependent increase in concentration of the genes, both HGF and interleukin-1 receptor antagonist in the early cell level. I'm not showing you all the data. I'm just showing you some data. Again, we did the insulin release assay. In this particular assay, we also tried to make sure that, so this is again the same assay that I've mentioned to you. I'm just trying to, and we did, in this particular assay, we also try to mimic the conditions that are present in human patients. In other words, as I mentioned to you, the islet cells are, there is apoptotic mediated cell death because of the presence of cytokines. So we basically incubated the islet cells with a cocktail of cytokines. Interleukin-1 beta, which again is a significant cytokine that is detrimental for development of apoptosis that leads to the death of the islet cells. And then we used tumor necrosis factor alpha and interferon gamma. So we basically used a cocktail of 3 cytokines, incubated them with the islet cells with the adenoviral vectors at 3 different concentrations. So we could see that most of the islet cells, at least at 1000 MOA, they basically showed, and in the presence of cytokines, they had glucose stimulation index similar to that of non-transfused islet cells. So thereby, based on this particular data, we next used again the MOA or the concentration of 1000 for our future experiments, especially the in vivo experiments. So again, this particular experiment, again, in the in vitro setting, we wanted to see whether, since we confirmed that, yes, the adenoviral vectors are expressing the genes IL-1RA. So the main function of IL-1RA is to protect the cells from apoptosis. And we did a caspase-3 luminescence assay. So caspase-3 is one of the important markers, or it is basically the convergence, is a convergence of the apoptotic pathway. So if you can, basically, when you try to determine the levels of caspase-3, it will tell you how, it will basically give you an indication of apoptosis in those islet cells. So again, we just compared, we had 2 different controls, 3 controls actually. One was a blank. We just used a blank medium to make sure that the luminescence assay that we're using is not coming from the solution only. Then we used supernatant from the cells that are being cells that are not transfused with any viral vectors. Then we use cells that are not transfused with viral vectors, but they are incubated with the cytococktail of cytokines and at 3 different concentrations of the viral vector. So again, we could see with increase in concentration, there was an increase in the concentration of the caspase-3. So based on this, we basically used an MOA of 1000. So that basically was not at a pretty high range. So there was some amount of caspase-3 or apoptotic activity, but it was not pretty high enough. Then we also tried to see at the protein level how whether this particular islet cell with this particular vector, whether it's going to protect the islet cells from apoptosis or not. So we did the Western blot analysis. So we basically tried to determine the concentration of 2 different proteins. One is BCL2, which is an anti-apoptotic protein, and BAX, which is a pro-apoptotic protein. So when you look at, and the anti-actin is basically a housekeeping gene. which basically tells us that when we started the assay, whether the protein concentration that we use, whether it is similar or not. So when we basically ran the gel for the 4 different groups, so we have to use the same concentration of protein. So actin, basically the darkness of the band should be basically similar in all the 4 rows. So that basically tells us that we are using the same concentration of protein, so that can give an authenticity to the result that we are showing. So we can see that in case of cytokine treated group, and in case of islets that are being incubated with cytokines, there was an increase in BAX-related proteins, which are again pro-apoptotic protein, and the concentration of the BAX of pro-apoptotic protein was less in islet cells transduced with the viral vector at 500 MOI, and it was very negligent in either viral vectors which are in islet cells that have been transduced with the viral vector at 1000 MOI. Similarly, if you look at the BCL2 or anti-apoptotic proteins, the concentration was higher in the islet cells that have been transduced with the viral vector. So based on this, we basically identified that we will use a concentration of 1000 MOI for our in vivo experiment. Similarly, we did this transplantation. We again transduced the animals with the adenoviral vectors in the streptozotocin-induced diabetic mice, and we could see that the not-skid mice which were transfused or transplanted with the islet cells transfused with the adenoviral vector, they basically showed a better decrease in glucose levels, and they basically persisted for at least 30 days. And at this particular time point, we basically, at this 30 time point, you could see that there is an increase in blood glucose levels in both the groups. So this basically means that we performed the nephrectomy at the end point, and when we removed the kidneys in which those islet cells were transfused, we could see that there was an immediate increase in diabetic. The next thing we also did was we wanted to make sure that these islet cells, like we did the glucose stimulation study, we also did an intraperitoneal glucose tolerance test to make sure whether the islet cells are withstanding to an increased concentration of glucose. So what we did was we basically injected 2 grams per kilogram of glucose in overnight fasted mice, and then we basically measured the blood glucose levels at different time points. And we could see that in the pink line, basically the animals that were transplanted with the adenovirus transfused islet cells, they basically tolerated better to the increase in glucose concentration compared to that of the control groups or the untransfused animals, not skid mice which were transplanted with untransfused islet cells. So this basically confirms, at least to a certain point, that indeed this particular approach is better. It can be beneficial in maybe coming out with a cure for, or can become a cure for type 1 diabetes or diabetes. The next thing we did was, again, after the end point of our study, we did immunohistochemical staining. So we basically took the kidney sections of the mice in which the islets were transplanted. Then we did the cross section. We did the immunohistochemical staining for insulin protein, for human von Willebrand factor, which again is a marker for endothelial cells that basically confirm that there are formation of new blood vessels. And then we did other one for human hepatocyte growth factor protein. So the top ones are the kidney sections of the mice that were transfused with the viral vector, and the bottom one are the control kidney sections of the mice that were transfused with this islet cells. So you could see that the amount of staining, or at least for insulin, because it's human insulin, was higher in adenoviral transfused islet cells. The same thing was seen with human von Willebrand factor, saying that there is development of there was vascularization taking place in islet cells, and also there was an increase in staining for hepatocyte growth factor, giving us the proof that there is expression of those 2 genes. So conclusion again, we could see that in these again with E1 and E3 deleted genes of the adenoviral vector, that they will it will make them replication deficient. These genes basically improve the allotransplantation outcomes. Again, we have to make sure that these vectors are safe from any immune-mediated side effects. So they should not elicit any immune response. So there needs to be more work needs to be done. Again, there are other types of therapies that are coming up. Right now, I specifically am working on trying to use a gene beta-cellulin. Again, I'm just trying to use a plasmid vector. But again, the advantage with beta-cellulin is it can, so this is particular gene that is expressed in the fetus. So it will help in differentiation and proliferation of beta cells or insulin producing cells. So when you use this gene, we can probably either enhance the survival and function of islets, or it can also help in improving the proliferation of islet cells. So this is what it is. Just other conclusion I wanted to tell you regarding the islet transplantation process. Again, this particular process is being done, but again, it is not it's an experimental procedure yet. Islet transplantation is still experimental procedure. So in, I think 2016, there was a study, they did a phase 3 clinical trial, and they found out that when they did this human islet transplantation, and this was without gene therapy, they did just using immunosuppressant drugs. In 1 year, they could see that 9 out of 10 patients, they became, they had islet, they basically had H1B/AC levels less than 7%. That is basically very important for diabetic patients. And then in after 2 years, they could see that at least 4 out of 10 patients became insulin independent. And this particular thing continued. So it's a very good therapy, but there are certain challenges which need to be dealt with. And so far, I think there have been around 1,000 or 1,086 patients who have been transplanted with islet cells. And it's again, the major problem I think is there's not much money being used for developing this particular therapy. With that, I will conclude, and I will take any questions if you have.
Thank you, sir, for sharing these views over here regarding with the gene therapy for diabetes mellitus. Now, I would like to request Professor Singhal ma'am to take a question answer session. Over to you, ma'am.
Good evening, sir. So,
Sir,
can you
audible.
tell me about the future of gene therapy? Can you tell me about the future of gene therapy in diabetes mellitus? Because right now it is not in so well practiced.
So yeah, so again, if you look at USA, there are only 3 products that have been approved based on gene therapy. So nowadays, adeno-associated viral vector products, they are the ones that are, there was one product that was recently approved, which was used to treat for blindness. As far as diabetes is concerned, again, it's a very challenging disease. Again, we know now there is no cure. So islet transplantation can become a cure, but we have to, so the future right now is, even in our lab, we have tried using adult stem cells. So one approach is to use stem cells, which can be proliferated, which can be proliferated to insulin producing cells. The other approach is to use stem cells that have been transfused with viral vector, and those are then basically co-transplanted with islet cells. That can probably enhance the survival of islets. So the future, as I've told you, islet transplantation as a whole is promising. Gene therapy again is something which there are a lot of studies being going on.
So one more question I'm having. Gene therapy it is now practicing type 1 diabetes. But what about type 2 diabetes? In an
So type
article I
2
have read
again,
it about.
yeah, I'm sorry, go ahead.
So I read one article. So it was written in that gene therapy is effective only in type 1 diabetes and not in type 2 diabetes. But
Yes.
most of the patients are suffering from type 2 diabetes. So what about the type 2 diabetes? Can you tell me?
So if you look at transplantation, it is generally, it's not given, transplantation is not done for every patient. So there is a condition called brittle diabetes that develops in certain patients. So patients who are not responsive to even insulin. So even if you give insulin to a patient, there is no decrease in glucose level. So there are other complications of diabetes that set in apart from the regular. So, and that can be detrimental for the mortality of the patient, or morbidity of the patient. So it's mostly given for patients. So so generally when you cannot basically, when there is no homeostasis between insulin and glucose, there is a condition called hypoglycemia that develops, which is very dangerous in patients. So again, in certain patients, they don't even know that they're getting hypoglycemic. In that particular scenario, you need a help of another person to help them out. So when you give this islet transplantation treatment, then those episodes of hypoglycemia are minimized. So in the transplantation clinical trial, I told you, in 9 out of 10 patients, they had H1B-AC levels less than 7%, and there were no hypoglycemic episodes, which is again very important for the survival of the patient. So type 2 again, type 2 is basically, it's understood that people get type 2 diabetes based on either lack of physical activity, obesity, and other conditions, or maybe pollution. We don't know. Another thing is there are different types of type 2 diabetes where a patient may have overexpression of and there is producing the insulin required to make so that there is a balance between glucose and insulin, but the receptors are sensitized. So it depends upon the type of type 2 diabetes. But if you look at the progression over a period of time, a type 2 diabetic patient will become type 1 diabetic patient. So that's going to happen because there is no cure for it yet.
So there is one question. Oh. So there is one question from Sarang Lokhande. Is it possible to avoid heritable diabetes by changing lifestyle?
By changing what? I'm sorry, can you?
Lifestyle.
Like,
daily routine, lifestyle, habits.
Even type 1 or type 2?
Heritable diabetes, hereditary.
So yeah, so hereditary it's very difficult. So I mean, you don't know. I mean, heredity means genetic. It can be genetic. So the problem is, type 1 basically means that it's autoimmune. So and it usually, if you see that occurring in either young patients, children, or adolescents. So lifestyle again, I have not seen any studies that say that with proper lifestyle you can maybe stop the development of genetic or hereditary type 1 diabetes. But it's always better to have a good lifestyle in any case.
So if someone is having question, you can ask. So Samir Lakde is having question.
Yeah, Dr. Samir Lakde, sir, you can ask.
Yes.
Ask your question.
Yes.
Good evening, sir. Thank you very much for your nice content, delivery of content. My question is, it is possible to have artificial pancreas to improve the glycemic control?
You mean artificial pancreas in the sense, what exactly are you referring to?
As like kidney transplantation, all things are going on nowadays in India also. But can it be possible in case of the diabetes mellitus, because nowadays the patients are more in a diabetes prone. So it is possible to have artificial pancreas. For the control of
artificial
glucose.
pancreas, yeah, I mean, are you trying to say that there can be some kind of a device
Yes.
that can basically be transplanted in the body, maybe subcutaneously, and then with changes in blood glucose levels, it will basically will be release of insulin from it.
Yes, sir.
So there are studies like that. I think there are studies which basically that's important too. So there are, I think, studies which basically because one of the major problems with diabetes type 2 or type 1 is so the way the islets function is, so whenever there is an increase in glucose, there will be a signal that will be received by the insulin receptor and insulin will be released. But the same thing we cannot do. We cannot do the same thing. So if we say that take an insulin dose every 6 hours, we may take it 5 hours, we may take it 8 hours, we may take it 4 hours. So we are not going to basically, we are not maintaining that particular timeline.
Okay,
so
sir.
there will be certain stages where there can be increase in elevated glucose levels for a more amount of time that we would like to see, and that basically over a period of time would lead to other diabetic complications. So to your question, there is research that is being done to have some kind of a sensor that's going to, so you basically implant a device subcutaneously, and then the challenge again is how do you detect an increase in glucose levels? So that is where I think the research is being done. So once you can find a sensor that can possibly detect like what the natural mechanism is, that there is an increase in glucose levels, that will basically trigger the release of insulin. So there is research being done. Again, that's again a promising area too.
That means to have implantation therapy in the
subcutaneously under the skin. So you will have a device that can be inserted subcutaneously so that it will not affect your day-to-day functioning. And you can basically, it will have a certain amount of insulin, which can be changed or it doesn't have to be an entire device. It can be attached to the skin, but it is present in your blood circulation. So that insulin can be released periodically.
Yes, sir. Thank you very much, sir. Transplantation of pancreatic islate be anticipated to minimize the risk. It is possible to generate the surrogated beta cells from the native of non-beta cells to replace the function of those cells lost from the autoimmune.
Yeah, that's the biggest challenge. That is also an important area of research that is being done. So again, as I told you, you can convert pluripotent stem cells to any kind of cells. So that's what the research is being done. So you have to, so as I mentioned to you, beta cellulin is one gene that can be used to convert those pluripotent stem cells into beta cells or insulin producing cells. But it's not very successful, but that's where it is one area. It's very difficult because islet cells are not, they're not regenerative. Yeah.
Okay. Thank you very much, sir. Thank you.
Okay, thank you, sir.
Okay, there is one question
Sir,
on my side. Yeah. Sir, what type of precautions we have to take when we are selecting the adenoviral for transfecting this gene?
Precautions in, so if you're talking about working with the virus, so this comes under biological safety level 2. So if you're talking about working with the viral vector, then you have to follow the proper precautions. You have to work under a cabinet with biological safety level 2. That's going to basically, which will come with a HEPA filter that's going to not circulate the air in the room. So it's going to basically filter the viral particles and vent it out. Then if you look at the treatment therapy point of view, you want to make sure, so we basically used a replication deficient viral vector, and this viral vector is only going to express the proteins, those two proteins, for only 14 days. So it's a transient expression. The second most important thing is when you compare these viral vectors with retroviral vectors, adenoviral with retroviral vectors are going to integrate into the host genome, but they have higher efficiency. but we don't want any viral vector to integrate in the host genome. So that's why we have used this adenoviral vector. And the next thing is there are studies where they could see some, as I mentioned to you, when you compare the concentration of viral vector from 1000 to 2000, we could see that there was an increase in caspase-3 levels, the glucose stimulation index level was less. So there can be some immune-mediated effect or some effect from the viral backbone. So you can also try to minimize it by even deleting a part of E4 gene of that particular adenoviral vector. So those particular viral vectors are known as gutless viral vector, adenoviral vectors. So these are the things that we need to be careful. We need to make sure when we are trying to. So the other studies that we have to do is we have to basically study the effect of these viral vectors on immune cells. And then we can see whether there is an immune reaction to these adenoviral vectors. That can give us a more good proof of concept that these vectors are safe and they can be safely transfused into human patients.
Okay, thank you, sir. One more question from our YouTube channel asked by Smita Pallivan. How cost effective is gene therapy in the respect of the Indian scenario?
Indian scenario, again, the pricing is regulated by the government. So if it is a therapy that is like this COVID-19, it will be, if it is for the, so there are two things, aspects to it. With the public health crisis, again, like for any other vaccine, for any disease, it will be subsidized and given to the patient. But as a general rule, especially in US, the cost of the biotech products is pretty high. The gene therapy, protein, and peptide products is pretty high. But when you do an analysis, when you look at the overall cost by looking at the decrease in hospitalizations of patients and everything, then you can say that it basically evens out, our gene therapy maybe or biotech products can be much beneficial.
So there is one question from Suraj Yadav, sir. Is there any criteria for treating diabetes mellitus by gene therapy by patient? Any biochemical variations have to be taken in consideration?
So as I mentioned to you, gene therapy or islet transplantation right now is only done for patients. In US, it's only done if they are enrolled in the clinical trial. So it's still an experimental procedure. And then it is only given to patients who have who are not responsive to insulin, or not, because that gene therapy is not done in human state. Okay, but human islet transplantation has been done in humans, but they use immunosuppressants. Because they use immunosuppressants, they have their own side effects. This particular protocol is on, or this particular treatment is only given for patients who are not responsive to insulin.
Okay, sir. So there is one more question. If someone is having a family history of diabetes, so for the third generation, there are high chances of getting diabetes mellitus. So what that person should take the precautions?
Eat less rice or chapati, I can say. But
shall I repeat the question?
Yeah.
Shall I repeat the question?
Yes.
Okay. So there is a family history of diabetes since 3 generations. So the third generation, whosoever is there, what precaution he should take for not having a diabetes or for not suffering from diabetes?
So again, family history in the sense you have to consider whether it's type 1 or type 2. So if it is type 2, like my dad has diabetes, type 2 diabetes. Or my grandfather had diabetes, but my mother doesn't have diabetes, type 2 diabetes. So in spite of you having a familial history of diabetes, it doesn't mean that you will get it. It just means that you have high probability of getting the diabetes. So as far as type 2 diabetes is concerned, you have to make sure that you eat properly, make sure you know what you're eating, and maintain exercise. Physical activity is very important. because that is one of the major reasons why type 2 diabetes develops.
Okay, sir. ANDE sir, any questions from YouTube section?
There is no such question it now ask. If there is will be any question regarding with this topic, we will carry forward to our eminent speaker later on also. So here we can conclude the question answer session. Now I would like to request Professor Neha Badukle madam to go for the valedictory session. Over to you, madam. You can unmute your mic and go for the valedictory session. Sir, there is one more question from YouTube channel from the same person, Smita Pallevan. Any studies which indicate that the regeneration of the islet is possible in human from other cell like alpha?
I've not seen any studies where they have done that. It's the only thing I've seen is on stem cells, trying to pluripotent stem cells and trying to use certain growth factors that can basically convert them into beta cells, but not on alpha cells.
Sir, okay, thank you, sir. Neha madam, you can continue with your session.
Am I audible, sir?
Yeah, you're audible.
Okay. Hello, sir. Good morning to all of you and good evening to our respected today's guest, Dr. Ravikiran Panakanti, sir. Thank you so much, sir, that you share such informative knowledge to all of us. And I want to say that topic was very good and you shared such a informative knowledge to all of our participants. So I'm very thankful to you from our Dr. Rajendra Gode Institute of Pharmacy as well as Dr. Rajendra Gode College of Pharmacy. You share really very nice and informative knowledge as well as you share your experience and you solve our queries. So I am very thankful from our both college and Institute of Pharmacy. Secondly, I want to thankful our Honorable President Sir, Dr. President Sir Yogendraji Gode from all our faculty and organizing committee that he helped us to organize such a nice webinar, international webinar. After that, I'm very thankful to our both principal sirs, Dr. Bakal sir, principal of Dr. Rajendra Gode Institute of Pharmacy, as well as Professor H.S. SAWARKAR sir, that is the principal of Dr. Rajendra Gode College of Pharmacy. After that, I'm very thankful to organizing committee, Professor SAGAR ANDE sir, as well as AJMIRE sir. Thanks for organizing such a nice webinar, that is the international webinar. I hope this webinar is very helpful for all faculties as well as students, that in all 4 days we gain so much knowledge. So I hope all students, faculty who joins as a participant gain so much knowledge. After that, I'm very thankful to all participants that they encourages us to by participating in our seminar, and I'm very thankful to all our faculties that they help all participants time to time. Thank you so much, sir. Again, thank you, sir. Dr. Ravikiran Panakanti, sir. Thank you so much, sir. Over to you, sir. Sagar, sir.
Thank you, Neha madam, for giving this valedictory session. I am thankful to our eminent speaker, Dr. Ravikiran Panakanti, sir, for delivering such a wonderful session for our participants and spending your valuable time over here, sir. We are in touch with you in future also, because this is the vast area and it is compiled with the biotechnology, so that most of the pharmacy student may know that that what kind of the era will be upcoming for the diabetes. Though there is a availability of the so many drugs, but problem is that the management required for the diabetes mellitus is for the prolonged period of time, and it's a hereditary right now, and so that the crucialty for arranging such kind of the therapy for diabetes mellitus is so much in need, because generation to generation, if it get transferred, it may be a much more problematic for the upcoming generation. So here now I can say that today's our session. Now I would like to request Dr. Jagdish Manwar sir to give their views on this webinar series arranged by joint venture of Dr. Rajendra Gode Institute of Pharmacy and Dr. Rajendra Gode College of Pharmacy, co-sponsored by Unique Pharmaceutical Laboratories Limited, Daman, Zim Laboratories, Nagpur, and Sun Enterprises, Rwanda. Over to you, sir.
Okay, sir. Very good morning to all the participants and very good evening to today's eminent speaker, Dr. Ravikiran Panakanti, sir. I'm Dr. Jagdish Manwar from Washington. So today, Dr. Panakanti, sir, enlightened us on the application of gene therapy to treat diabetes, to treat type 1 diabetes mellitus by transplantation of islet cells. It was indeed very informative session, and I am extremely thankful to Dr. Panakanti, sir. Thank you, sir. All the speakers of last 4 sessions were very brilliant and extremely interactive with us. They shared knowledge about the current picture of facets of pharmacy going on globally, and we learn new things, new concepts, and new ideas from there. The speakers really made us proud being an Indian by the work they do. I hope they will guide us whenever we need it. I want to congratulate to the organizing committee of Dr. Rajendra Gode Institute of Pharmacy and Dr. Rajendra Gode College of Pharmacy, AMRAVATI, for arranging such a global webinar series by inviting such a dazzling and very much enthusiastic persons from United States of America. I thank all the speakers and one of the most hardworking principal, Dr. Bakal sir, and his enthusiastic team members, especially Principal of Dr. Rajendra Gode College of Pharmacy, Dr. Sawarkar sir, Dr. Sagar sir, AJMIRE sir, then Garibe sir, Adol sir, and all other sirs and madam for thinking about this global innovation about our pharmacy profession. Today, I feel this is one of the best attempts by your college to transform our pharmacy profession to dynamic level. Today, I am living this series with almost reluctance. Really, I enjoyed this festival of knowledge by staying at home. Made last a few more days more beautiful and more memorable. Thank you all. Thank you, and thank you.
Thank you, sir, for giving your views. Now I would like to request Dr. Samir Lakde, sir, to give his views regarding with this international webinar series. Over to you, sir.
Thank you, sir. Good morning to everyone and good evening to the honorable speaker of today's webinar. Honorable guests, speakers, respected principals, faculty, fraternities, and the students. Good morning to everyone. Hi, this is Dr. Samir H. Lakde, working as an associate professor and HOD in pharmaceutics department at RMD Institute of Pharmaceutical Education and Research in Pune. It's my privilege to have a proposed vote of thanks on this occasion of 4 days international webinar on the facets of pharmacy. I extend a very heartfelt gratitude to all the speakers for gracing your important works and sharing with us your findings and opinions. I must mention my deep sense of appreciation to all the speakers one by one, since they have took the sessions long back 4 days. On a first day, Dr. Balwant Chauhan sir from the AUHS School of Pharmacy, who had given the topic impact of pharmacogenomics in personalized medicines, where he had enlightened us on a personalized medicine in a deep and vast manner. I'm very much thankful to him for enlightening and giving a much more information about this and improving my knowledge on a topic of pharmacogenomics, where it is we face a difficulty in each and every sectors. Now, the second day, the Dr. PRASHANT Sakarkar sir from the Roosevelt University of College of Pharmacy spoke on the topic evidence-based synthesis, where mainly he was focused in his talk, concept, process, application of evidence-based medications, nuts and bolts of evidence-based medications, and how to practice the evidence-based medications, because this topic was very critical and this practice is not going to be conducted or practice in India. So it's very difficult to understand this topic by ourselves. So he has simple way presented the topic to understand each and every nuts and bolts of that synthesis of patient care for evidence-based medications. I'm very much thankful for him for providing the knowledge regarding that topic. Now, the third speaker, I take this opportunity to extend my sincere thanks to Dr. Rahul Deshmukh sir for his step-by-step guidance on a cancer immunotherapy with his nice content and the presentation. Simultaneously, while his talk and the delivery of content, he has solving our doubts, every participants. Thankful to him for again enlightening us on the topic and more, making more knowledgeable to us. I'm very much thankful today's speaker, Dr. Ravikiran Panakanti sir, for valuable guidance on this topic of gene therapy. Again, the diabetes is very common to India also, but the therapy and the research which you are carried out in your own place, it's very renowned us, and the topic is unknown for us, that is a gene therapy. So by providing and sharing your knowledge, it's a very us to be a part of this seminar in your nation. Now, finally, at the bottom of my heart, for the big thank you to Dr. R.L. Bakal sir, a principal of Dr. GODE Institute of Pharmacy, AMRAVATI, who are very humble, open-hearted, research-oriented, visionary leader. Let I congratulate him first for successful completion of this program. Event like this cannot happen overnight. So when to make this program, the will starts a way back of weeks to require planning and dedication. This won't be possible without the vision of this leader, his hard work, his willingness and involvement. And entirely not a single person is responsible to conduct the webinar like international seminar webinars, but the entire faculty of the SIOP and the College of Pharmacy, both the principals did their work hard, and the entire team of both the institutes did well. I especially acknowledge the way in which the entire program was started first at the before the timing they started, and at the time they end up. That means I just want to acknowledge everything about that, the start and the responses and the communications, continuation in contact with all the participants in the WhatsApp group and the Telegram is so fantastic at that place of Amravati. So I'm very much thankful to the coordination of every people in the both the institutes, and finally to both the principal for organizing such a international webinar. And I am very much lucky to have the participant of this webinar. Thank you very much for my kind words.
Thank you, Samir sir. Now I would like to invite Professor Ranjit Ade sir to give his views regarding with our international webinar series. Over to you, sir.
Thank you, sir. I am audible, sir?
Yeah, sir, you are audible and your visual is also clear.
Namaskar, sir, and good evening to all our eminent speakers, and very warm good morning to all. Myself, Ranjit Namderao Ade, lecturer in pharmacy from Geeta Devi Khandelwal Institute of Pharmacy, Akola. I am here to express my views and feedback on 4 days international live webinar series, that is Facets of Pharmacy, organized by Indira Bahudeshiya Shikshan Sanstha, Buldana's Dr. Rajendra Ji GODE Institute of Pharmacy and Dr. Rajendra Ji GODE College of Pharmacy, Amravati, in association with our co-sponsors are Unique Pharmaceutical Laboratories, Daman, Zim Laboratories Limited, Nagpur, and Sun Enterprises Limited, Rwanda. And this is very proud moment for me that I was an ex-student of this institute's parent branch, which was located at Malkapur. First of all, I like to express my gratitude towards Dr. Rajendra Ji GODE Institute of Institute and College of Pharmacy and Associates for organizing such a wonderful, informative, interactive 4 days international webinar series and for accepting and considering my participation. All the sessions which are covered within these 4 days are really very informative, interactive, and knowledgeable. As per my views, what I learned from these eminent speakers or personalities. So my answer is, being a teacher, I learn teaching styles of the eminent personalities, the way of their expression, PowerPoint presentation. They are very kind and knowledgeable and many more. And with this, the transfer of knowledge is also takes place. So I'm also very I'm very thankful and heartfelt thanks to congratulate, express heartfelt thanks towards respected Dr. Ariel Bakal sir and respected Professor H.S. Sawarkar sir. Both are teaches me, and I say thanks for organizing such a wonderful and interactive and knowledgeable training program for us. Definitely, with me, my students are also benefited because of this training. I like to extend my thanks towards Dr. Yogesh G. GODE sir, President IBSSB's College of Pharmacy. Then overall organization, coordination, and communication before starting and during the session is very good. I like to congratulate to Professor S.N. ANDE sir, Professor AJMIRE sir, Professor GULHANE sir, and team for their restless efforts for successful completion of this international webinar series on facets of pharmacy. So thank you, sir.
Thank you very much
And
for
over to you, sir.
your views regarding with this international webinar series. Now, at the last, I would like to request our respected principal, Dr. Ariel Bakal sir, to give his views regarding with the whole series. Over to you, sir. Yeah, sir, you are not yet audible. Yeah, now you are audible. Yeah, you are audible now, sir.
First of all, good evening to Professor Ravikiran sir, and good morning to all my participants. I am very much thankful to all my eminent speakers, Professor Balwant Singh Chauhan sir, Professor Prashant Sakarkar, then Professor Rahul Deshmukh sir, and today's our speaker, Professor Ravikiran sir. Without their support, it is not possible. Again, that is our sponsors, General Manager of Unique Pharmaceutical Limited, Mr. Parmeshwar Bang, then Mr. Prakash Sapkar, Director, GM Laboratories Limited, then our another sponsor, Mr. Sanjeshi, Managing Director, Sun Enterprises Limited, Rwanda, Africa, and lastly, all my participants and my team members. Due to their effort, it is possible. Again, I am very much thankful to my all eminent speakers and my participants. Thank you. Over to Ande sir.
Thank you, sir, for being with us for this session. I would like to express my gratitude to the Dr. Ravikiran Panakanti sir for giving us such a wonderful presentation and giving a valuable time for us, sir. We would like to express our gratitude on the behalf of Dr. Rajendra Gode Institute of Pharmacy and Dr. Rajendra Gode College of Pharmacy. Thank you, sir. Thank you very much for being with us and guiding us. I would like to request the participants to give their feedbacks on today's session. The feedback link will get available, or I think so it's get available in a chat box in a on a YouTube channel and in a WhatsApp group. So we can carry forward all the queries and feedback of today's session to our eminent speaker. So being with us for on tomorrow also, those participants who has given all the 4 days feedback form, the link of the certificate will be sent to them on their mail IDs, registered mail IDs. Now, lastly, I would like to conclude this session by giving a thanks to our all the eminent speakers, Dr. Balwant Chauhan sir, Dr. Prashant Sakarkar sir, Dr. Rahul Deshmukh sir, and Dr. Ravikiran Panakanti sir for being with us, spending a valuable time guiding us in India, for all our participants and from the different continents who join us with this international webinar series. We always intend to organize such a kind of the webinars from eminent speakers who can guide us in a particular path, as like you can say that we started with the medication precision, or we can say that the personalized medication, then we jump over the precise medication, then during current scenario of the pandemic where the immunity gain a more importance, and how to look over in relation to the cancer, that also concluded. And at the last, that is nothing but the gene therapy. All are connected and well channelized. I thanks to Dr. Prashant Sakarkar sir for guiding us and giving us such a wonderful eminent speakers to talk with our all participants, for their guidance and for their support throughout the program. Here, I would like to also express my thanks to our sponsor who believe in us for organizing such kind of the international webinar series, Unique Laboratories, Unique Pharmaceutical Laboratories, DAMAN, Zim Laboratories, Nagpur, and Sun Enterprises, Rwanda. At the last, I thanks to all my colleagues and faculty members for giving me support and to make this event successful. Thanks to all for giving your efforts. Here, I declare that today's session is going to be concluded over here. Thank you, sir. Thank you very much for being with us.
Thank you. Thank you very much. Thanks for the opportunity.
Yeah.
I wish you all the best.
Yeah. Thank you, sir. Stay safe, stay happy, and being with us in future also. Thank you.
Bye. Bye.
Bye.